So today I'm joined by Greg Lehman. Thanks so much for giving up your time and having a chat with me today, Greg.
Yeah, thanks for having me.
So for people who are not familiar with you and the work you do, if you'd like to give us just a quick background of your work and then what you're involved in at the moment.
Oh, okay. My background was first in kinesiology or exercise biomechanics or occupational biomechanics. And then I did a master's in that at Waterloo with Stu McGill and all the great occupational exercise biomechanics researchers there. Mainly on, EMG activity during exercises. And then we did a lot of manual therapy research. And then I went to Chiropractic College and I was able to keep doing research there. And we published maybe 20 or so papers again on exercise biomechanics. And then I was in practice for 5+ years, and then I went back to school for physiotherapy, and I still practice full time in my clinic. And then now, I got away from doing research and teaching, and I was lecturing for a long time, for 5 years there too, and I was just in practice. And now I'm starting to get some more balance where I'm teaching more now, seeing fewer patients, and starting another research program in pain and exercise biomechanics would be the ideal area. Yeah.
Fantastic. So it's a very broad background you're coming with. And what we're going to talk about today is primarily pain, because although when we mention pain, everyone knows what pain is. They think to know what it is anyway, but it's a very interesting area to get into, kind of get into nitty gritty. So I'm going to start off with a very broad question, and feel free to expand on this as much as you like. What is pain?
Yeah, I'm never good with memorizing definitions, but I sort of like Laura Mosley's take, where it's not what it is, but what it's useful for. And he uses the word that it's meant to motivate an action, right? And so people will say that pain is produced by the person. It's multidimensional, and it's meant to get you to do something. So it's the perception that the body's in danger, and you need to create an action to help yourself out. What's great with the word perception, it doesn't always mean that you're in danger. You just have to think that there's a threat. And that's the idea. So sometimes it means there's tissue damage, but it's just the perception that there's the potential for tissue damage. And sometimes we get caught up in thinking it's just tissue damage, but it's more that key word of potential is the idea, or the perception of the possibility of tissue damage.
Exactly. And you mentioned pain there is multidimensional. What exactly do you mean by that?
Yeah, that's what's so cool. I mean, it means that I kind of use the word, pain is more about sensitivity than damage. That phrase, and so you want to say, what in your life can be sensitizing you, or what in your life can contribute to you thinking that you need to protect yourself. Right, so it's a tissue damage or nociception from the tissue. These are our surveillance detector systems. That's one part of it. But then you get that information, and then you or your brain, whatever the philosophical debate is, make a decision. How relevant is this information? Is this nociception? Do I need to have pain to help me out here? And that's influenced by a number of factors. Like if you have a past experience of having pain in that situation, then you're probably more likely to have it. If you've had a history of pain, then it can amplify your nociception. So there's a number. That's the thing. You can never be sure. It's just multidimensional. It's kind of like almost anything where the brain's involved. Like fatigue is multidimensional. Like if you do a cycling time trial where you're doing 400-meter repeats, or you're doing your squatting to failure or bench pressing. Your perception of fatigue, it's influenced by lactate or hydrogen ions in the tissue. It's influenced by the baroreceptors. It's influenced by how much, energy storage you have left. But then you make a decision of how tired you are, your perception of effort. There's other factors that go on involved when it comes to performance. It's not purely physiological. And it's the same with pain and vision and all these emotions that we have. Other emotions that we have.
From a practical perspective, what kind of factors within our lifestyle influence our perception of pain? Because the same stimulus often can result in different levels of perceived pain. So although the same thing might be occurring one time, it might be much more painful than the other. So what kind of factors that we can control in our lifestyle have an impact on our perception of pain?
Yeah, that's a really nice question, because you said the same stimulus can lead to like a different output. And that's kind of the idea. It's like the same amount of tissue damage or irritation. It's like our response to it. It's kind of what we do to it. And I as a clinician, or when I work as a strength coach with people with pain, I often feel like I don't know. Like I get, like, I say, well, why do they have pain? I know pain's multidimensional. And you're like, okay, I have to figure out everything that's going on and causing it. And maybe you don't have to. Like, I don't think you necessarily do, and I don't think you always can. You try to figure out the areas that might be contributing, but you don't always have to. So I use the expression of treating with a really wide net. And I say, okay, these are all the areas in your life. And, what can you do to be healthier in all of these areas? Because you can never specifically parse. You can't say it's 20% from depression, it's 13% from anxiety. Wow, it's 33% of fear of movement. It's 50% because you weren't sleeping well. You just like with an athlete, you say, how can we make you better in every area of your life? Just like with performance, and we do the same thing with pain. And then you're always thinking, okay, now is there something specific, that definitely looks like it's contributing as well. So treat global. Be the best healthy human you can, and then try to get the specific stuff. That's what I would do too.
Exactly. And one thing you alluded to there, Greg, was the fear of movement. So pain also alters our biomechanics, or our fear of pain alters our biomechanics. What kind of level of impact does the fear of movement or the fear of pain have on our biomechanics?
I think a lot of the fear of injury has a huge impact. Like I coach my kids I don't officially coach them. I help them with gymnastics, and they're trying to go inverted and go upside down, and myself too when I do handsprings. And what's funny, sometimes what you think is going to be helpful, like when you go upside down and do a backflip, what you want to do is stay tucked, right? You want to tuck in and go to your feet. When someone has fear and they go upside down and they freak out, the thing that they do, which is straighten out of it, is actually the worst thing that you can do for an injury. Yeah. So it's funny, we often, the thing that we think is, our body thinks is most helpful, can be the worst thing. And that's what will often happen with people in pain. They get into a habit where they keep doing the thing that aggravates them, and they don't even realize it. So sometimes our job as therapists is to break that habit somehow and give them different ways to move, different ways to sensitize it. Because I don't think there's one ideal way to move. I think some people, for whatever reason, when they get in pain, they keep doing the thing that aggravates them. And our job is to say, well, try moving this way. Try a more extended spine or a more flexed spine. Don't brace as much. Brace more. Like, give lots of options to me to desensitize. It's how I work when it comes to pain. Rather than thinking they're missing some ideal technique. It's like they just keep doing the shit that hurts.
Yeah, fantastic. I really like that approach. It's an individual. Everyone's biomechanics are unique in each individual way. So obviously pain is one of the big things around the industry. A lot of people trying to treat pain. In terms of clinicians and that kind of thing, what do you see are the most common misconceptions around pain and maybe pain sources?
Well, that's hard to say. Like, it kind of depends on the field. I do think we get. I think it's that in North America, the biggest thing is the kinesiopathological model, which goes to saying you have to move in this way. If you deviate from this specific posture, or posture also meaning dynamic posture, you're going to be more likely to get injured. To me, that's not irrelevant, but I think it's overdone. I think your knee can go inwards and collapse immediately, and you won't be likely to have knee pain. It's maybe a factor under some conditions, heavy loads, not a lot of knee flexion, not controlling that motion. But for many people, we can get away with a lot, and there's nothing wrong with it. We get caught up on ideals, and we focus on those things rather than looking at the bigger picture. Like, someone's not sleeping well, there's other stressors in their life. They just have shitty training. They're just training too much. They're not following the 80-20 rule. They're doing like 80% high intensity and only 20%, slower stuff. Or if you're working with young kids and they're in multiple sports, guaranteed most of their workouts are at a super high threshold in intensity, because the coaches can't work together, so they hammer all their workouts, and they never have easy days. So what I would say is we don't focus on like the big rocks and the really important things when we get caught up on these little nitty gritty things.
Yeah, exactly. And I think there's a big movement towards movement variability. It's been viewed as a good thing now and kind of protective against injury going forward. So throughout your kind of work, you'll see this phrase coming up, and that is pain is purely or poorly related to damage. What exactly do you mean by that, Craig?
Yeah, I mean, initially it's probably better related when you break a bone. It usually hurts when you strain a muscle. Pain's pretty good. It can tell you that something's going on, but after time, it's disconnected, right? The best example would be stay with a broken bone. It can hurt at the time. It's in a cast. 2 weeks later, it's in the cast. 2 weeks later, say it's your tibia. It probably doesn't hurt. Yeah. It's still damaged though, right? That's a perfect example. That bone is broken and you have no pain, right? So that's of course, if you move it and load it and shift it around, it'll probably hurt. And then the other idea of pain's poorly related to damage would be we have this fantastic technology that's just too good. We have scans and MRIs and ultrasounds, and we confuse again things that look weird, like we call them degeneration and abnormalities, when in fact they're normalities. They're normal responses to age and use, and we freak out because it doesn't look like it should look in a textbook. Even though I swear I'm saying this stuff for 20 years. I remember in 1996 in my master's looking at stuff on the spine, and I found a case series of it was like 8 people with herniated discs, massive herniations with nerve root pressure, and 6 months later they didn't operate, and none of them had pain, and they still had those herniations. Like, none of this stuff is new. We've been saying the same shit forever. It's just not trickling down.
So essentially, a lot of time, if you're experiencing pain, it could be coming from a range of sources. You go get a scan and these abnormalities show up. But really, if you had a cohort of 10, 20 people, they're all going to show some abnormality because we're all unique in a certain way. So, as you say, abnormalities are actually normalities. They're normal things to see. There's no clear-cut textbook image of what everyone should look like.
Yeah, and you can't say those things might predispose. Like, you have a tendinosis, so if your tendon looks weird on an ultrasound or MRI, and it doesn't look healthy, it's not irrelevant. Like, it doesn't have to hurt. It might predispose people to a little bit of pain. So I always call these abnormalities or degeneration like kindling for a fire. It might predispose you to a flame, but if you just put a bunch of wood on the ground with little bits of paper, it's not going to turn into a fire. You need like a spark and an accelerant and oxygen and all those things, so it's just not enough. And then what's great is I like that analogy. I'm just complimenting myself here. It's like laughing at your own jokes. Is you don't actually treat the kindling. You don't have to treat the degeneration. You treat the things that make it sensitive. You can remove the oxygen. You can put water on it. You can do all these other things. The kindling can still be there. Like, you don't have to get rid of a labral tear. Yeah. It doesn't have to heal, and someone could be functioning fantastic. I love that idea of the body being resilient and adaptable.
Brilliant. And if we take it to a practical example, say we have clinicians or people within practice, what would be the steps that they should go about practically to determine the source of pain and then implementing a recovery strategy? So what kind of considerations should they have?
That's tough, because then again you're trying to parse out what the things is, what's aggravating them. So still do your regular exam. Do a really good orthopedic exam. You always want to rule out tissue pathology. It's still important. If something's damaged and requires healing, then you work on that. You want to rule out sinister red flags, all of those things. Right, and then to me, you want to find just a regular, like we call it in chiro school, low Dr. Fakera, like what's aggravating it, where is it, how does it move around, like just the standard exams, and still treat the physical, find out what's aggravating them physically, and then you make a decision. Like with the physical stuff, you have to decide: do I need to expose them to the thing that hurts or protect them from it? Right? Because you can't, if someone's avoiding the thing that's aggravating them and they're not prepared for it, then you slowly have to build them up to tolerate it. But some people are poking the bear too much, right? And they have to be pulled back. So that to me is always my clinical challenge. Like, are you doing it too much and keep aggravating yourself, or are you afraid of it or desensitized and you're not prepared to handle the physical stuff? So for the physical things, it's always, do I need to expose, or do I need to protect, or is there something in between? So that's my big thing with physical contributors to sensitivity. And then your other questions in your history are, what's different in your life? What has changed? So it's almost the same thing. That's what we ask with the physical exam. What's the change in the physical loading? Are you doing too much too soon? And then you would say the same thing with all the other stressors. Do you have any new or unmanageable stressors in your life? Right? And really open-ended questions. Because if you jump in and start saying, like, you can ask people directly, are you depressed or anxious, if you have that relationship with them. And there's nothing wrong with that. Some people will, and it's good, we don't want to stigmatize mental health. But some people will, if you don't know them that well, they can push back. So you start with general questions. How's your sleep? How's your work stress? So if we think of injury as like it's our failure to adapt to load or to stress, it's not just the physical loads, it's all of the loads. So that's the multidimensional. So what are the loads? What are the stressors going on in your life? It's not that they're inherently wrong, but are there ones that are now unmanageable? So then it turns out, well, I do have some depression and it's been worse lately. And you say, well, it's not always in our scope, but what are you doing to manage it? You don't have to get rid of it because that's not fair. Or, I started a new job and it's really physical and I'm stressed out at work, so I've been hammering my workouts. Well, those are kind of the times where you got to back off on your workouts because you're doing so much at work. So big question. That's kind of all over the place, but
no, I like that because it's much more of a kind of, I don't like using the term holistic very often, but it's much more of a holistic approach, because a lot of people will just view, what are you doing physically? But you need to look at the comprehensive picture of that. Everything we do in life is just a series of different stresses, and it's all about balancing the stresses and kind of getting the appropriate level of stress to improve, but not going too high that the stress is negatively impacting our ability to adapt and improve.
Yeah, that's perfect. I don't know if you know Jeff Kubos, but he just posted a nice question. He asked someone, what are the unmanageable stressors in your life? And it's the word unmanageable is so nice because you're not vilifying stressors, right? It's not the stress, it's our response to the stressors that's the problem. It's the same thing when we went back earlier, you talked about like an injury. It's people's same input, people have different levels of pain. So it's the same thing with stress. You have different levels of stress and people have different responses to it. And our ability to adapt to stressors will fluctuate over time. So you're like, do we need to back off of these stressors? Or can you learn to tolerate them? And that's always our question.
Exactly. And I think Tim Kabat, I don't know if you're familiar with the work of Tim Kabat out of Australia, he's a nice term. He said, load is not the problem, and say load or stress is not the problem, but it's rather the load or stress we're not prepared for that is the problem.
Yeah, and riffing on that's I like the idea of movement preparation or preparation, but I would also say, and I think his research would support, or at least his literature reviews in his papers, it's there is a finite adaptability, right? Like although he talks about the acute to chronic ratio, like, and that you can slowly build up your chronic load, there is going to be a ceiling of the chronic load that people can tolerate. And we shouldn't think that everyone's just infinitely adaptable, right? So there is some point in time where we have to back off. Everyone needs to back off and say, all right, that's the limit of your adaptability. But for right now, this month, this 6-month span, this cycle, so it's okay to back off. That's my only caveat with Tim's stuff. And I don't think it's Tim. It's probably how people misinterpret his work, of course. So that's everyone. Yeah.
So the other area you're very much involved in, obviously biomechanics is the main thread through it all, but one thing we often hear people associate a lot of pain towards is posture, and there's a big kind of emphasis on the way we should sit, stand, that a lot of back pain is just from slouching or that. What is your take on kind of this dogma that's going on that everything relates back to posture and we must ensure perfect posture, and that a lot of our modern day pain problems are related to sitting all the time with bad posture?
Yeah, think posture is incredibly important for performance and biomechanics, right? Like I said earlier, I'm learning back handsprings and stuff like that. And all my sports before have been forward. I don't have a lot of shoulder extension or back extension, and my back handsprings suck and my shoulders are killing because I'm really trying to get more. So for performance, posture, absolutely focus on it. For pain, not so much. Like when you're sitting, who cares? The loads are so low, you would adapt to them. Who cares if your head is forward? Like they use the word the 42-pound head. It doesn't really matter. It's not much that much load at all. Like our spine is designed to tolerate that load. It's no big deal. Like our spine is articulated. That's why it's meant to bend. It's just, and the research doesn't support it that you have to sit up straight. And again, like I remember back with Stu McGill, we would take pictures and go into offices. We wouldn't always go in office, and we'd teach people, sit however you like. Put your feet on. This is 20 years ago. This is not a new idea that posture is not that important. Put your feet on your desk, cross your legs, slouch backwards, slouch forward. Put your keyboard on your lap. Don't get caught up on ideals, especially with, like low load activities. It just doesn't matter. But if you're going to do a head spin, then it's probably better to be in neutral just because it's such high load forces. But hanging out, it doesn't matter.
And what would be your take on the argument? One thing's kind of we often see people come to us particularly with is they've been told that they can't squat properly because they've tight hip flexors from sitting down all day. What would be your take on that kind of stuff?
So this is where biomechanics always challenges biomechanics. We don't need to talk about pain science or psychosocial. That's just shitty biomechanics. Fuck. Sorry, I've been saying. I remember a really good strength coach saying that, and I wrote him. Not like I just sent him a personal email. Said it makes no sense. Your tight hip flexors, when you squat, you're flexing your hips. Your hip flexors are being slackened. Like it makes no sense. Oh, they say your hamstrings. I'm like, no, not your hamstrings either. When you squat, you're flexing your knees. So it's not a hamstring factor. That it just makes no sense at all. So everyone will say, oh no, if you sit all day, your hip flexors are going to get tight. And they'll say, then you can't do this activity. And I always say, well, why don't you spin it and say, look how fantastic your squatting will be because you're practicing squatting all the time now. Because now you're like sitting. We just no one spins it that way. Yeah. So it makes no sense. You could argue. I think the better way to argue would be for thoracic extension, right? If you're sitting all the time and you do no sports where you ever extend, and your habit is always to flex forward, then for thoracic extension, it'll be an issue for your squatting or something. But as long as you get up and do something other times of your life, 8 hours of sitting, which no one does, they're always getting up and moving. I guess it's probably 5 hours at the most that people do in an 8-hour shift. It's no big deal.
Fantastic.
It does make sense.
Yeah, I'm really glad you said that, Greg, because that's one of the kind of the pet peeves that a lot of people come to us with, and they're constantly being told, it's all down to your tight hip flexors from sitting. But as we said, when we look at the anatomy and biomechanics, it just doesn't make sense.
No. So much is like that of biomechanics. You don't even that's why I love talking about biomechanics. That's where the debate should be. Get your biomechanics house in order.
Exactly. And we're nearly coming up on time, Greg. So before I ask you the final question, if people are looking to get in contact with you or follow your work, where's the best places to find you?
My website's good. It's just greglehman.ca or Facebook. Well, Facebook or Twitter. Twitter's good. I like talking on Twitter.
Perfect.
Website and email and that stuff.
Perfect.
I was just in Dublin. I won't be there for a while. Dublin was great.
It's unfortunate now. So I'll put all the links like that into the show notes. People find them easy enough. So the final question I like to ask everyone, Greg, is what is the biggest mistake that you have made or the biggest learning experience that you've had that's changed the way you approached either your career or your mindset in general?
Yeah, I'm kind of lucky in that a lot of people had to go through like a revolution. They got taught a certain way that was kind of outdated. I was really lucky where I was exposed to the psychosocial model really young, and I was exposed to chiros who are good critical thinkers, and Stu McGill is a critical thinker. So I never had to get rid of a lot of myths and debunk things. I started pretty young reading that stuff. However, you always question yourself, and sometimes you fall off that wagon and you you get caught up in trends. So I'm still subject to that. But I think my biggest problem that I've had is, and mistakes that I've made with patients, when you go into the psychosocial model, and you never ignore the physical, but you can probably get a little too excited if you want to teach your patients about pain or psychosocial stuff or how the brain's involved with pain or performance, and you can freak them out, right? And even if you deliver the message really well, about pain being multidimensional and the brain's involved, not everyone needs to hear that. And they might hear you saying that it's just in their head. Yeah. Even if you talked about the body and all those things, always our communication, doesn't matter how good you communicate, there's someone on the other end and they might hear certain things. So I always say go really slow when you're introducing those new concepts. And anytime you're challenging someone's beliefs about posture, that's hard too. And I think we all can be better in that area, like taking a motivational interviewing class or reading books on that, because people are really inundated with the idea that posture and tight hip flexors matter, or that they have muscle adhesions in their fascia or something sticking or their tissue isn't sliding. And you might want to correct them right away, and you can lose them, and then you can't help them. So you have to ease into like behavior change and changing people's opinions. And I know I've lost patients because I've been too excited about trying to bring them to my side or whatever. So just go slow. That's where I've sucked, and everyone can get better.
Fantastic. And before I let you go, just after
fantastic at sucking. Thank you.
It's a fantastic message, and I hope people can take something away from it, Greg. But before we let you go, another question just occurred to me. I think it'd be a shame to let you go without asking. What do you see are kind of, in terms of mobility, biomechanics, recovery, all the things related to, we hear all these things about fascia, tissue quality, scar tissues, lesions, all these things. What do you see are the kind of the biggest myths or misconceptions and trends that are out there at the moment in terms of biomechanics, physical therapy, chiropractic, or whatever?
Well, it depends on the area. I think, I don't get into the debate, like a misconception. Can you give me like a specific, depend on the topic. Do you want to talk about fascia or like specifically in fascia? Yeah. I think the biggest one, an area that we don't know enough of is hand, like people do manual therapy, would be hand delivered mechanotransduction, right? Like, that's such a neat research question. Like, does, with fascia, do layers of fascia stick together? Does fibrosis really form? The epimysium, does that stick? Does fascia not slide? And if it doesn't, can our hands actually go in there and catalyze that reaction, that mechanotransduction reaction, to change tissue quality? To me, that's such a under-researched area. And people, like for me, and I said it 15 years ago, I'd be treating a hamstring tendinopathy, and I'd be doing active release technique, and I'd be digging in hard, and I'd be thinking my thumb is catalyzing a reaction in the tissue. It's an external force, and the tissue's going to have to adapt. That was my thought. I don't know right now. My bias is to say that probably isn't happening, but some people really think that's what's going on. And I don't think anyone can have a strong opinion either way, because the research just really hasn't been there. So that's just one area. It's not so much a myth. It's just something that gets promoted, and we can't really say either way yet.
And would that translate into your opinion on foam rolling? Because I know foam rolling and self-myofascial release is one of the biggest trends. There's a lot of people making some very heavy claims around it, but the research just doesn't seem to be there at the moment, does it?
No, I mean, again, I was one of the people who was against foam rolling quite early. It didn't make sense, because even active release never made sense, breaking up adhesions to me. I just couldn't figure it out. And then when foam rolling came out, people were saying the same thing. That doesn't make sense. So, but what you have to be careful of, me is certainly when you're critical like that, is, are you against foam rolling, or are you against what people say about it? right? Like I'm not so. If someone wants to foam roll and they get a little bit of increase in range of motion, because some people certainly do, and they feel better doing it, how can I be against that? It's just, I would just be more hesitant when people are like, you have to foam roll because you have to break up these adhesions, and if you don't, that's preparing the tissue, and if you're not doing that, then you're a bad strength coach, you're a bad therapist if you don't advocate that people foam roll. Like that stuff's too far. But saying, if you want some increased range of motion and you've responded to it in the past, by all means, go ahead. As long as you're not missing doing other important things like a warm-up and strength training and all that other stuff.
Exactly.
That would be my take.
And I think that's the perfect kind of critical approach to it, that if someone's getting a benefit to them, because I think as coaches we can sometimes be very quick to dismiss something if there's no science behind it, the research isn't there. But as an athlete, if they're doing it and it's not causing any harm to them, well then, as a coach, if they're perceiving a benefit for them, we should just let them do it once it's not at the expense of something else that could benefit them.
Yeah, you said it much better than me. That's it exactly. And another thing you have to be wary of is someone who feels like they absolutely need the foam roller and then they're relying on it, and so their beliefs about their body, like I have all these knots, I'm all messed up. Then it's a crutch, and then it's definitely a big issue that's getting in the way as well. That would be another example there. They have to get off of. I work with Paul Westwood sometime. We have a new running course coming out. Paul Westwood's like a triathlon physio, and his big thing is to go in and like toss it. And he works with very elite, the Olympic caliber triathletes, and just tosses out their foam rollers and massage sticks. And he goes stronger than me. You're like, because they just view their body. They view their body as so fragile, right? That it needs, like, that's the problem with performance care. It's like, I need this manual therapy work or I can't perform. Like that like we're this car that needs so much tuning. And is that getting in the way? That's always the debate in there.
Yeah.
I need ART done or else I can't run my 100 meter or something. That's not uncommon. And those are good therapists, and that's a nice debate. I'd like to talk to them about it.
And this concept people have of the muscle tissue is actually knotting, is that analogy kind of very incorrect? Because people have this idea that their muscles can literally knot and they need to work out these little kinks within the muscle fibers.
Yeah, it's assumed that it's fibrosis, that it's the start of scar tissue. It's such a ART, the active release thing, that's really no evidence. Right? I mean, fibrosis occurs if there's trauma inside a knee, or fibrosis can occur with a hamstring strain. But I'm really doubting that you're going to remodel that tissue with your hands, because it's freaking tough to remodel it with that massive loading from exercise. So the amount of load you can get with your hands is nothing. You can only bowstring a tissue. You can't even create tension in it. You can just compress it. So it doesn't make sense to me. And there's a study by, I like this one, Uring, I'm probably saying his name wrong, about fibrosis after hamstring tears. Yeah. And they compared two groups in who would have recidivism or recurrence of injury. So both groups got through the rehab, was strong, they were allowed to return to sport. One group had tons of fibrosis, and the other group didn't. They had a lot less or none at all. And they want to see who was more likely to get injured, and there's no difference between the groups. So even something where it's fibrosis that shows up on an ultrasound or a scan, that's not even predisposing people to injury. So tiny little things that don't even show up and people just say they can feel, which is bullshit. It's just different non-homogeneous tissue. It doesn't make sense. It just views the body too frail for me.
Yeah, exactly. It goes against this idea then that everyone has to be, there's one uniform thing that everyone needs to fit into in terms of movement or their tissue quality or what their tissues look like. We need to kind of get away from that textbook style image of everyone needs to look like this, and if they don't look like this, they're predisposing themselves to injury. Yeah.
And then back to the manual therapy thing. I don't want to knock active release or those myofascial treatments as being helpful. It's again, what they say is that really, really supported. That would be the idea. There's still some. I think there's still some utility in doing that, just for other reasons.
Exactly, and we need to just really, before we start making some stark claims, we need to engage in a lot more research and get kind of stuck into that area much more. So it's Absolutely enlightening having you on, Stephen Greg. I hope there's plenty of stuff people will be able to take away and get some real value and apply it to their own practice or in their own training. So thanks so much for giving up your time and having a chat with me today.
Yeah. Can I plug the free book?
Of course, can. I'm going to put it in the show notes anyway, but go ahead.
Oh, okay, perfect. Yeah, it's the recovery strategy book. It's always free. People can do with it whatever they like. It's a 70-page. It's essentially 70 pages of like a pain guidebook, but it's set up as infographics, so you can just print out one page if you want. That's sort of the idea, where if you're working with someone in pain and you think you want to change their views on pain, giving one message at a time instead of just like hammering them with pain science. That book's set up so it's one message, like, pain is more about sensitivity than damage, or degeneration is just wrinkles on the inside. It's like, it's nice to have someone else break the news rather than you say something that might be challenging their beliefs. That's the idea.
Yeah, it's fantastic, and I recommend that book highly to everyone listening, and it will be in the show notes. People can download it directly from there. So thanks so much for your time, Greg.
Yeah, thank you.